Good morning, tribe. We're here this morning with Marion. She works with organ recovery. It's been a while since we've gotten to chat with someone, and so I'm excited to get back into the swing of things and hopefully find some normalcy in life. So, good morning, Marion.
Good morning. Hey guys.
So, you've been in organ recovery for a little while. Tell me about your process of
Yeah.
organ recovery.
The process becoming an organ recovery coordinator or what I
Yeah,
do.
and how long you've been doing it.
So I've been a nurse for 10 years. I've been in an organ recovery coordinator for almost 4. And then previously I was a PICU nurse. I was a PICU nurse for 7 years. So
And how do you feel like that prepared you for organ recovery?
So, it to be in organ recovery, to be an organ recovery coordinator, which is what most nurses who are in this job do, you have to have at least 2 years experience in an ICU setting. So, for me, it definitely prepared me for that. It's a lot of critical thinking. It's a lot of autonomy. It's a lot of being comfortable in making your own decisions. And so within the pediatric ICU, I feel like I don't even know if I would have felt comfortable with 2 years experience in this job, but I did PICU for 4 years and then was a supervisor, a nursing supervisor for 3. And I think that all that together, like management of a unit and management of staff and like different things, all of that together really prepared me very, very well for this job. And I think it all those skills that I learned within PICU really set me up for success in this job. But really, anyone who has ICU experience and is interested in organ recovery can learn on the job. And because it is one of those jobs that you don't learn stuff in nursing school, like how to take care of a donor patient. And so, really, it's experience on the job and training on the job that gets you prepared for it. So,
So the next question you already answered, and maybe you have something you want to elaborate. Is this a good place for a new grad to start? The answer is no. But
no. So,
how should they steer their career path as a new nurse or someone looking to go into organ recovery?
well, the funny thing is that most nurses don't even know that this job exists.
Uh-huh.
It's kind of one of those specialty jobs that, like, when I became a nurse or when I decided I was going to be a nurse, I had no idea that this even existed. I mean, I knew that people were organ donors, but I had no idea the process and did not know that nurses were involved in it. And so, looking back, like, thank God I worked in the pediatric ICU at UNM at a level 1 trauma center where we had donors, because I probably wouldn't have even fallen in, or not fallen in, but taken this job because I wouldn't have known it existed. And this is my dream job. This is the job I love. But I think if someone wants to do something like what I do, an organ recovery coordinator, you definitely need to have a good, solid, like, basis background in nursing. So I think starting in a on a floor for at least, I worked on a floor for 6 months because I was in a residency program, but 6 months to a year, at least having floor nursing and then working your way up to ICU is exactly where you want to be. And then, if you're in a level 1 trauma center, that's definitely a place where you'd want to be because that's where the majority of your donors are. The majority of our donors in New Mexico are at UNM Hospital. And so you will get a chance to take care of donors on the nursing side, and that's where a lot of our organ recovery coordinators like began to understand and learn that what my job is actually a nursing job. So
Yeah. So do you have a specific certification or anything like that for your specialty?
I do. So I have what's called the CPTC. It's the Certified Procurement and Transplant Coordinator certification.
Oh, wow.
So after 2 years, I took that exam, which is it's very similar to like a CCRN or anything like that. The process, at least, you
Yeah.
study, you sign up, you pay for it, you sign up, and then you take the exam. And if you pass the exam, then you get your certification. And then I think you have to, no, I know you have to renew it every 3 years, and you have to have so many like CEUs and that kind of stuff to maintain it, just like any other certification.
Right. Okay.
And
And
the only difference is that to have this job, you don't have to be a nurse. The majority of people who do have this job, at least in New Mexico, in fact, all the people who have this job in New Mexico are nurses. In other states and other OPOs, organ procurement organizations, which is what New Mexico Donor Services is, they don't necessarily all have nurses, but definitely nurses are part of their workflow and part of their organization.
Okay. So what are the top 3 challenges, would you say, to organ recovery for you as a nurse?
So I think part of it is, I think the biggest thing is changing your thought process. You know, as a nurse on an ICU, your thought process is save the patient, save the patient, save the patient, save the patient. And in my situation, 90% of our donors are brain dead donors, meaning that they've been declared brain dead and have been declared dead and are legally dead. And so it your thought process flips to not saving the patient necessarily because they're passed, but trying to optimize end organ function,
Yeah.
and really like reversing all the effects of brain death, because when you have brain death, there's all kinds of different things that happen, all kinds of different processes that fail within the body, and so you're trying to combat that. And so it's trying to get good end organ perfusion, but also you're kind of on a time, so like really paying attention to how long things are taking, working up the patient quickly and trying to find matches. And so your goal is not saving the patient, it's saving the organs so you can save other patients. So a lot of people are like, why are you doing all these things for a patient that's dead? Well, behind every one donor, there could be 5 other lives. And so you're focused on saving those other lives, not the donor. So it takes a little bit to kind of like flip your brain to like really focus on like the end goal, which is these recipients that are going to get organs. The other thing is it can be taxing. Sometimes you're constantly dealing with end of life. That's your only job. And it's not end of life like hospice, where like families have come to the decision that they want to, you know, um, take these patients home, or keep them in inpatient units, and they've come to the decision that they want to do end of life care, and they're with the family. A lot of times all these things, a lot of times our most of the times our donors, it's like a tragic situation. It's like a sudden situation where like one day the patient's alive and the next there's a trauma or a bleed or something like that. And so it's really like it can sometimes be like very high drama, high stress, and you're working with always end of life. I mean, like when I get referrals, the referrals are always situations where the patient has a really poor neuro injury or the family's going to withdraw, and so you're constantly getting calls about patients dying, and so that's your baseline. And so it takes time to get used to that, because especially in the pediatric ICU, yeah, we had poor outcomes, but in a pediatric population, like 90% of the time, you have good outcomes, and patients get better and go home. And that's not what this is. And so getting used to that can be challenging. And then the last thing I think that's challenging for me is that you don't have a home unit. So we cover the whole state of New Mexico, and I work pretty much by myself. There's one organ recovery coordinator for every 24 hours on a case. And so I'm going into a unit as a guest, but then am supposed to manage and am in charge of the medical management of that patient. So I'm telling nurses, like, these are the orders we need. This is what we need to do. We need to give this. This is your priorities. But I'm not actually a part of that unit. I'm an outsider coming in. So you're a guest, but you're also kind of in charge. And it's finding a way to have like good relationships while you're also asking for all these resources, and then not really being at home. You don't have, I have resources that I can call, and I have or recovery coordinators that maybe are second call that I can call, but they're not there. And so you don't necessarily have that like network of support that you do when you're on like a home unit,
Sure.
taking care of patients. And so that took me a little while. I really had to like kind of come out of my shell and be comfortable with like making friends immediately. So that was hard for me at first as well.
So you're not actively titrating drips and doing those things. The nurses are.
Correct. I'm directing it. I'm guiding it. So, I call it like organ donation medicine is not like an exact science. And there's not a lot of research on it. There's a lot of barriers to research that I won't get into, but so there's not a lot of research on it. So a lot of it is based on what has worked in the past, we continue to do, and that's everywhere in the country. Um, and then, of course, you rely on your critical care experience to also help. But sometimes we're giving patients like an insane amount of potassium or an insane amount of insulin, something you would never give an alive patient, but that's what they need. So it's working with the nurse. The nurse is the one continuing to titrate, give meds, help with all the exams and evaluations. But I'm the one kind of acting like as the medical provider. So it's kind of like being, not that I'm saying I'm a physician, I'm not, but it's kind of like being a physician and a nurse and a social worker and a family care coordinator and a manager, like all at the same time. So yeah, everyone is still doing their roles. Like the physicians will sometimes we'll get critical care consults if like we've hit a wall and we can't figure out how to help with the patient. Will The nurses usually are one-to-one nurses or one-to-ones because they're so busy. We still use CT, we still use cardiology, pulmonary. We'll get your renal consults. So we still use all those resources, but we're kind of like the managers. We're like the main people who like get everyone together to get all this stuff done for the donor.
So about how long are you managing these cases in like a best case scenario prior to someone coming
Recovery.
to recovery? Yeah.
Yeah. So, I mean, in a best case scenario, we would like them to be like 24 to 36 hours. But in reality, our donors take anywhere from 36 to 72 hours. And I'm mostly talking about brain dead donors because that's what we do mostly. There's also a donation called donation after cardiac death. So that's a patient that's really, really sick, is not going to make it. The family has decided to withdraw. They're not brain dead, but the family decided to withdraw, and they're sick enough that once we remove life support, they're going to pass within like an hour to 2 hours. And so then they pass and we rush them to the OR. So in
Yeah.
those situations, those are shorter time periods because there's no management. Like what you have on the patient is kind of what you get. And so you just evaluate for usually liver and kidneys. And so those cases are always going to be shorter. But for brain dead donors, especially, the more potential they have, like if they're a 6 organ donor, meaning heart, lungs, liver, kidneys, pancreas, potentially intestine, that would be an 8 organ donor. Those take longer because the workup takes a long time. So those are like our 3-day cases. And then the more teams you have coming in to recover, the harder it is to get everyone on board with one particular time. And so then that sometimes, and then working with the OR can really extend out our time as well. So we would love it to be shorter, but like really a full organ donor with a lot of potential can take up to 3 days.
So you said yourself, you said that you're on 24 hours
Mhm.
shifts, right? So you would
Yeah.
physically be at the bedside of that patient for 24 full hours?
Correct. Yeah.
Oh,
So we do 15 up to 15 24-hour call shifts a month. But that's a combination of first, second, and third. So generally speaking, I mean, we have what we call like high donor times when we have multiple donors at one time. But the state of New Mexico is fairly rural and the population's pretty small. And so we're a very small OPO, and we generally don't have more than one donor at a time. And so usually first call is the person that's on for that 24, and then second call is their backup. And then if it's weekends, we have third call, which is like the backup to the backup.
mhm.
So I would say on average, I maybe am up for 24 hours, like 3 times a month. That doesn't mean that at the other times I don't work. We have referrals we have to do. We have office stuff we do. We have community things we do. We work with the hospitals. We have referrals we follow up on. So there's a lot of stuff we do outside of just the donation part of it. But I would say like on average 3 times a month I'm up for a full 24 hours with a donor. But then yeah, they do take a lot of management, and I'm not only managing the patient, I'm also, once it's time, I'm also finding matches. I'm working with transplant centers to give them information they need. If they want more evaluation or more testing, I'm working with our team to see if that's feasible. I'm working with the family. So there's a lot more that's going on than just me asking nurses to do different things for evaluation or to work up the patient.
So let's go to the family side of things.
Mhm.
When we as bedside nurses get a referral for an end of life case, and you guys come in and discuss that with the family, is there a certain art or approach that you like to use in discussing organ donation with the family?
Yeah, definitely. We get training on how to work with families and work in this, like really like high stress, situation where a lot of times it's shocking and there's a lot of grief involved, and so there is definitely a rhyme and reason to what we do. But it also really depends on the family. There are some families who ask about donation, and then it's a lot easier because they've opened the door for it.
Yeah.
And there's a lot of families that we know, like their culture doesn't necessarily support donation, and so then there's a whole nother way to kind of speak with families. But really, it just comes from a place where we have empathy and compassion for what they're going through.
Mhm.
And so when we go in with that and like really show genuine care for that patient and that family, even when we get a no, it's generally a good conversation. We're not there to convince anybody that they should be organ donors.
Mhm.
We're there to support their decision, their end of life decisions, and to support them with in this whole situation. So of course um, we're gonna advocate for donation, because I've never had a family come back and say, "Oh, I wish I hadn't donated." We have had families that have come back and said, "I wish I had done donation."
Yeah.
And so we're always going to advocate for that, kind of looking to the long term, because it's very easy to think like short term right now, like my loved one is dying or is dead, and think short term. But we're asking them to think long term, that this person can have a lasting living legacy. But the other thing that we have at New Mexico Donor Services, and that really nationally they have, is we have family care coordinators. And so I'm not going in alone. In fact, generally speaking, our family care coordinator is the one that's starting those discussions, and then we're there like for clinical help. Like if the family's asking, like, well, how do they know they're brain dead, or what's the process, or what are you going to do, we're there for that clinical side. But the family care coordinators, their sole job is to work with these families and help them to understand the process and to help them through this journey, not just in this moment, but like long term.
Okay.
So yeah, so we have that those staff that can help us with that, and so it's really a joint effort to talk with families.
So is the family care coordinator also a nursing physician?
The family care coordinator, I mean, it could be a nursing position. Our family care coordinators right now come from like a social work background.
Okay.
But yeah, it could be a nurse. But they're usually they don't do any clinical stuff. So nurses usually want to do clinical, and so they do the organ recovery coordinator. But there have been some organ recovery coordinators, not currently, but in the past, who have decided they don't want to do the clinical aspect and move over to family care. It's definitely a very specialized skill, and it's definitely something that it's really hard to talk to families about this situation. And so timing is really important and that kind of stuff. And so I think that it takes a really special person to be a family care coordinator. Um,
Mhm.
and so sometimes people don't necessarily they do it, and then it doesn't necessarily work out for them. We're very lucky to have two great family care coordinators right now, and so we love them and we rely on them a
That's
lot.
awesome. So once a family agrees to organ donation, the
Mhm.
next steps for you as a nurse, can you talk
For
a little
me as the organ recovery coordinator, or you
yes,
as the bedside nurse?
you as the organ recovery?
What's my next step?
Yeah.
So it depends on the type. So we're going to focus most on brain death, because that's where the majority of our work is done, is in brain dead organ donors. We would take over the management of the patient. And so in that case, what happens is, if a family decides to the patient's going to be an organ donor, then New Mexico Donor Services is going to take over the cost of everything from that point on, because we would never want families to have to pay more for their loved one to be an organ donor. So we take over all the cost of care, and then we would set up a whole new order set for the patient. We would work with the nurses to put in those order sets under our medical directors. And then we are continuously monitoring the patient. We order our different evaluations, an echo if we need it, a cath if we need it, CTs if we need them, bronchs, percutaneous liver biopsies, whatever we need, depending on the patient and that kind of stuff, to evaluate the patient, and also putting them on different protocols like a T4 protocol if we need to, because they're on a lot of pressors, or steroids, stress dose steroids if they're not doing well, or specialized antibiotics if they've had cultures that are growing, different things like that. And so we're working with the nurses to put in these orders as protocol orders, because we do have protocols that we loosely follow, but here at New Mexico Donor Services, we also have a lot of autonomy, because we have a fair amount of critical care experience behind us. We do have a fair amount of autonomy to do a lot of critical thinking, to determine what those patients need, because we are the ones there at the bedside, seeing the patient, working with the patient. And then of course we have help. We have an administrator on call who is generally a more senior member of the organ recovery staff, or a manager, who we can also look to if we're stumped. And then of course we have our medical directors, who are amazing, that we can also call 24/7 to ask them if we need to ask them about different things, different management, or different things. If we're concerned that we're looking at a patient and they don't have potential because of different things, we'll talk to them about that. So we'll work with the nurse. The nurse will put in new orders. She'll follow through with she or he, excuse me, will follow through with those orders, give whatever medicines we order. They'll help us go to various evaluations and exams. And then they'll manage that patient just like an ICU patient. They're a nurse just like any other ICU nurse would be. The only thing is, instead of going to the medical team for questions, they're coming to the ORC for different things, and giving us hourly urine output, and hourly glucose checks, and hourly vitals, and that kind of stuff. And then I, on the other side of that, am putting all this into our system, and getting ready to put it into DonorNet, which is the UNOS, EMR, I guess you could call it, the UNOS EMR, so that I can eventually make matches and then send out offers based on the list that gets run. And then I send out offers, and then different centers look at those offers, and it's literally very objective, 1, 2, 3, 4 down the list, until we find an appropriate recipient for this particular donor. And then we set an OR, and then we go for recovery. And then in the OR, I don't want to say I run the OR, because that's not really what I do. What I do is I make sure that everything's being done under regulations. There's a lot of UNOS regulations and UNOS policy that we have to follow, and things have to be done in a certain way. And so I'm there kind of as the hawk looking over the whole OR, to make sure that everything's done per policy, and that they're packaged per policy and sent with the right teams per policy. And so I'm kind of the overviewer that makes sure everything's done appropriately. And then I am responsible for that organ until it goes to whatever transplant center it's supposed to go to.
Wow. So those transplant centers come into the OR as a collective entity,
Yes.
and harvest, is that the right word?
Recover. We use recover.
Okay.
Yeah, that's why we don't use that word anymore.
No, that sounded horrific. Sorry for anyone who may have offended.
No.
Recovered those specific organs for whatever patients they're going to go transplant them to at their home institution.
Correct. So, it's not necessarily always that way in every OPO.
Okay.
It kind of depends. In New Mexico, since we're so small and relatively rural and don't have a really big population, for transplants at least, we only transplant kidneys locally in the state of New Mexico. And so if I needed a heart, if you needed a liver, if someone else needed lungs, we would have to get listed at another hospital. The hospital in New Mexico would refer us to another hospital, another transplant center, and we would be listed at that transplant center.
Okay.
And so here we only have surgeons that can recover kidneys.
Okay.
So we would only locally recover organs if they're kidneys that are going to be that if we're only recovering kidneys.
Mm-hmm.
And it's pretty rare that we have situations where that's all we're recovering is kidneys. And so everything else, we don't have local recovery. Other OPOs sometimes will, the doctors there know each other really well and that kind of stuff. And so they will maybe sometimes have local surgeons recover. But generally speaking, surgeons are really specific about how they want things recovered, how their patient's vasculature is, what their patient needs, what things they're looking for. And, sometimes we don't see abnormalities until we open up the patient sometimes. You can do all the CT scans and everything in the world, but sometimes you don't see the whole picture until you open a patient up. And so those surgeons know like what their patient can tolerate and what they can't. And so transplant centers, are usually very specific in the way things are recovered,
Mm-hmm.
especially when it comes to heart and lungs. So almost always heart and lung surgeons will come and recover their own organs. Every so often we can have a liver surgeon recover for another liver surgeon if they can't come, but that's relatively rare here in New Mexico as well. So if I'm allocating heart, lungs, liver, kidney, and pancreas, I'm probably going to have 4 teams come out. The only surgeon that will recover something for somebody else is a lot of times a liver surgeon will recover both kidneys for us. And that's because kidneys are generally pretty straightforward. The anatomy is usually pretty normal and straightforward, and what one recipient needs is the same as another recipient. So I could have up to 4 surgical teams come in, and that's usually a surgeon with an assist and at least 1 perfusionist per team. So I can have up to like 20 people in a room at one time, and up to like probably 8 surgeons, like kind of doing different things at one time if you have a full donor. Yeah.
That's amazing.
Yeah, it's pretty incredible. They come in on private jets. They have priority for like takeoff and landing because they are on a time. They're on a schedule like a heart. Um, it from the time it comes out of the body to goes into a recipient is supposed to be 4 hours. They say 4 to 6, but really a surgeon wants 4 hours. A lung is the same thing, 4 to 6 hours. Livers are 8 to 12 hours. Kidneys are the ones that can last for a really long time outside of the body, and those actually sometimes get pumped and can be out for a couple days, but that's an exception. Pancreas is also pretty quickly, and so they're definitely on a time. And so it's not one of those things where they can mess around. Like sometimes if we have a high traffic heart and liver lung teams, we'll get lights and sirens. Definitely at their center, they'll get lights and sirens. They'll use helicopters on their end if they need to, whatever they need to do to get the organ there on time.
Wow.
So yeah,
So
it's pretty incredible.
Yeah, that sounds amazing. So I'm going to just talk about the one time that I specifically had the opportunity to see the patient go into the OR from a bedside nursing organ transplant side of things. I had been a part of organ recovery or organ transplant nursing as you are giving orders as the bedside nurse. Yes, but the one time that I actually was part of the team that took them to the OR. That patient actually came back to the unit. How often does that happen? Like he was not able to organ donate because he stayed alive too long.
Right. Yeah. So that's in a DCD situation.
Okay.
And so of course, in those situations, it's relatively, we try to make it as controlled as possible, and we try to guess if a patient's going to pass. So in a brain dead donor, when we do the evaluation, we go to the recovery. We're going to open up the patient and we're going to recover. Almost always we recover at least something.
Okay.
For a DCD, for a donation after cardiac death, the patient is not dead yet, and it's not ethical nor is it legal to take a patient and recover organs that are alive, right? So what we have to do is if that patient wanted to be a donor or that family wants the patient to be a donor, then what we have to do is withdraw life support, let them pass, and then very quickly go to the OR.
Okay.
And the problem is that, once you withdraw life support, usually a patient decompensates. And after about an hour of having poor perfusion and poor oxygenation, cells in those organs start to die, right? Organs are only viable for so long without oxygen, and without them being cold and getting preservative solution flushed through, which is what we do, when we take them for recovery. And so what happens is if we try with using different tools and talking to the teams and seeing what medications they're on and seeing how much support they're on, we try to guess, an educated guess as to if they're going to pass or not within
Sure.
like an hour to 2 hours. But you can't always get it right, and so
Mhm.
sometimes they don't pass within the amount of time. And so what we do is we talk to the family and say, if they want this, we're going to do comfort care no matter what. And when I say we, in that situation, it's also not right for me to take over care of the patient, right? Because I don't want to impact if the patient's going to die or anything like that. So I make recommendations to teams just based on like, hey, we probably need some antibiotics. Can we start this antibiotic? And then they decide what's appropriate for the patient. And then they do all the comfort care. So they would take care of that patient and do whatever comfort care like they would any other patient who's on comfort care or withdrawal life support. So they're going to give whatever medications they would give to a normal patient. And then we just let nature take its course and see what's going to happen. A lot of times it's up to the patient, it's up to the donor if they're going to pass or not. And if they pass, we very quickly take them to recovery. And if they don't, then we just take them back to the unit, and the team continues comfort care like any other patient they would do withdrawal life support on. I would say that a patient will not withdraw, or would not pass, excuse me. Oh, I don't know exactly, but like maybe one in every like 10 maybe that we have don't pass. It's not extremely uncommon. I mean, it's not extremely common, but it's not uncommon.
Okay.
And our logic for that is, one, if the family really wants it to happen, then we're gonna try if that's what the family wants or if the patient was registered. And the other thing is, we're not really being aggressive. I don't want to use the word aggressive. It's not in a negative connotation. It's in a positive connotation, meaning we're trying to get more organs to be transplanted. So we're not really being aggressive enough. We're not really trying hard enough if we're not having some patients that don't pass. Does that make sense? Then we're being too conservative. So we just take those in stride and say, we tried, the family wanted it, we tried, and it didn't work out, and that's okay.
Interesting. Yeah, a comment came in. In my role as an ED nurse, I make a lot of referrals. Actually, my department as a whole makes a lot of referrals that end in successful donation. We get a letter every quarter telling us how many lives were saved or improved because of our referrals. It's always a somber letter to read. You remember weird things like the 19-year-old male who had braces or the 36-year-old woman who had twins. Had twin 2-year-old sons. It's such a mixed emotional experience to read the letters. For us, the donor is more immediate and tangible than the recipient, who we will know nothing about. Donation's a very good thing. What you do is incredible.
Oh, thank you. I appreciate that. I think it's incredible too. I do tell people though, it's a double-edged sword, right? Like someone has to pass in order for someone to live. The thing I always try to remember is that the team doesn't, I mean, like no matter what ICU you're in, almost always the team has done an incredible job of trying to keep that patient alive and doing everything they possibly can to live, for that patient to live. And so it's not anyone's fault that this patient has died. It's something that's going to always happen in healthcare, in an ICU setting, patient or ED, even an ED setting, patients are going to pass. And so it's taking something that was going to happen no matter what and trying to find something positive that can come out of it. And whether they can be an organ donor, we didn't even talk about tissue donation, which is a whole separate side where a lot of patients can be tissue donors that can't be organ donors. It's a really special thing. I tell families, it's kind of like an elite group of people that donate. We had, I think, something like 30,000 deaths in the state of New Mexico last year. And out of those, only 58 people, or maybe 55, 50 some people were able to be organ donors. And that's because you have to be in this very specific place. You either have to be brain dead or very, very sick, but still stable to do all the workup. So they have to be in a very specific set of circumstances in order to be an organ donor. And so it's really I know it sounds weird, but it's really kind of a beautiful process when you think about it that way, that these people are doing something that very few people in the world will ever be able to do. And they have this living, lasting legacy. You know, they've died, but they live on in others. And it's really like an incredible thing when you think about it. And it gives me chills and I get all emotional all the time when I think about it. And so that's why I do what I do, because I just think it's amazing. And we would not be able to do it without all the ER nurses and the ICU nurses and the ICU doctors and the ER doctors and every RTs, like everyone who works so diligently to do it. I mean, it takes a lot of resources for patients to be organ donors, and we're lucky to have amazing relationships within our hospitals here in New Mexico. And they really work so hard for people to be organ donors. And so that's why, yeah, we send letters out saying like, hey, you were involved in this case, and you know, 4 people are living because of it, and we thank you and applaud you for your support. I mean, we do that here all the time. We actually keep a list of people that were involved in the case, and we try to get them emails or letters or something so that they know the outcomes, so that they know that they've impacted not only the life and the family of the patient who was lost, but the lives of so many others. And, you know, you save 4 people, 5 people, whatever, but you actually impact so many more people, because for every one life, there's, I mean, like how many family members who don't have to go through the end of life process because their family is saved with an organ. And so it's really like you're not just impacting that one recipient, you're impacting so many others that are tied to them. And so it's this huge community of people that are forever linked together, and it's pretty amazing.
That's awesome. So if you, first of all, how many, what's the turnover in your area? Is there readily jobs available, or is your team pretty solid?
So, you know, it depends. So currently in New Mexico, we have 5 full-time and 1 like part-time, because she's also an AOC and um, what is it called? Administrator on call. She does both.
Okay.
So we have 5.5 ORCs right now that cover the whole state of New Mexico. So only 5.5 people in the whole state do this job here.
Okay.
But in other places, they have large OPOs, like California has multiple organ procurement organizations. Our sister OPO, Tennessee, they have a bunch of ORCs because they have a huge state with a huge population. In those places, the turnover can be relatively high, just because the schedule can be a little crazy. There's no routine. You never know what's going to happen. You could only work like 8 hours in the day. You could end up working the full 24 hours. Um, you could be at home working or in the office working. You could be on site for a full 24 hours. So it just kind of varies. There's no norm, there's no standard. And so I think they say that the turnover, like average, is 16 months.
Wow.
It might be 18 months, something in that place. But here at New Mexico Donor Services, we have a pretty stable staff. We don't have a whole lot of turnover. I've been here for 4 years. Alyssa's been here for, well, almost 4 years, 3 and some months, 3 and like 8 months, something like that. Alyssa's been here for 5 years. Mickey's been here for 4 years and some, and then our younger ORCs or ORCs, I think everyone's at least been here a year. So so we have a fairly stable staff. But when we do have open positions, what we do is we have in-house coordinators and hospital development staff that work really closely with the hospitals, like even when we're not there. Um, and they will like let ICU nurses know, like, hey, you at one point said like this would be a cool job to have. We have a job opening, and we kind of do it through word of mouth. I mean, of course, we put a position up and post it, but like I said, a lot of nurses don't realize that that's a nursing job, and so a lot of it is like word of mouth, telling ICU nurses that we worked with, like, hey, if you're interested, like you could apply for this job. So we meet a lot of nurses that we work with because they were a bedside nurse for a donor at some point. I mean, that's how I fell in love with this job. That's how I found out about this job, is I did donors as a bedside nurse. So I was on the bedside part of it and was like, what you guys do is incredible, and that's what I want to do. It took me a while to move, but when I did it, I didn't look back. I love my job.
That's awesome. Well, I won't keep you too much longer. We've talked for quite a while. Is there anything that you want to tell us? Maybe something you love, which you've already talked a lot about what you love, but maybe the hardest part of your specialty?
Well, like I said, sometimes I think the hardest part for me is the family aspect because you never know what you're going to get.
Mm,
Some families are very pro donation. Some families, sometimes we have situations where the person has decided to be a donor. They've decided to register to be a donor, and the family doesn't necessarily know that, and they're not necessarily supportive of that decision.
mm,
And that's when we have to kind of get them on board. Those are like the harder situations because we really want to advocate for the patient. And if the patient registered to be a donor, that's what we want to do. And so it's, getting those families to understand the process. Like I said, we've never had a family come back and regret that their family member was a donor. But we really don't want a situation where they come back and they're like, if only, like, I really should have, had them be a donor. So I think
right.
the family aspect for me is the hardest. Um, just because, you really have to continuously adapt to whatever the family needs, and really show genuine compassion and concern. And sometimes that can be hard because it makes you have to kind of be raw and in the moment. And sometimes to get through this job, you don't want to be there because you want to, protect yourself. And so it's finding that balance of like protecting yourself and also maintaining having a good relationship with the family, and figuring out where your boundaries are, and how you take care of yourself and protect yourself and still be there for the family. And then the other thing is 24 hours shifts are hard. I mean, being up for 24 hours, I tell people, people are like, oh my gosh, you do that? And I'm like, well, doctors do that. Like, that's kind of like how we function as like on-call physicians. When they need us, we're there. And when they don't, we do whatever else we need to do. Uh, but the patients are usually fairly complex, and so we need to be there 24/7.
Yeah.
Um, and so, that can be really hard and really exhausting if you have multiple in a row. I think that's where the burnout a lot of time comes through, because a fair amount of OPOs do 24s. I mean, if they don't, they do 12s, but even 12s, like back to back to back to back, like going down for 12 and then, gutting home, you only really have like 8 hours down and then being up
Right.
at 12 again. So even 12s can be exhausting because you're really on the donor case the same amount of time, except mine's extended like for 24 hours and theirs is like multiple 12s.
Yeah.
Either way, it can be exhausting and um, challenging. And so that in and of itself can burn you out pretty quickly. And so, like, there's a lot of like learning, like self-care and taking care of yourself and that kind of stuff that I don't know that I did as a bedside nurse very well, but have learned that I have to do that in this job.
Nice. And in New Mexico specifically, we could go on and talk to you for hours and hours, but we won't. We will wrap this up soon, I promise. If anybody
No
has
worries. I don't have anything else to do, so we're good.
okay.
Not
So,
today, at least. I'm not on call.
oh, okay. So you're giving us your time off. You're the best. So the 24 hours that you're on, you might be in the outer part of northern New Mexico
Mm-hmm.
or, somewhere. So at
Yeah.
that point, do you stay there and sleep?
So that is a little different. It depends on the OPO and it depends on where you're working. Here in New Mexico, our manager is really, really good about our safety. And so what we'll do is a lot of times the person who starts the case will drive out.
Okay.
And we drive because to get a charter here to fly is going to take almost as long, if not longer, than to just drive.
Yeah.
So we'll drive to the place. We have company cars that are part of like the enterprise system. And so it's a fleet management system. So they're always like well taken care of and safe. And we get like new cars every 3 years. We take company cars out. So the person who starts the case generally will take a company car out. And then after that, because we're on for 24, and we don't want the person over there to necessarily be on more than 24, although you end up being on more than 24. What a lot of times we do is have a driver drive the person that's going to come. They leave at 6 in the morning and drive out, but I don't have to, I'm not the one that has to drive. I just get to like rest until we get there. They drop me off and then they pick up the person who was on and then drive them back.
Oh,
Um,
okay.
the other thing we do is if we don't have that option, or we've decided we don't want to do that, what they can do is they can get a hotel room after they get off at like 9 or usually 10, because by the time I get there, it'll be around 10. They can get a hotel room, sleep, and then when they're ready, get up and drive home.
Okay.
So we always have options. The other thing that sometimes happens if I'm like first call, second call, first call, and we have another case going on, or there's stuff going on, or we just think it's stupid for me to like go up, come back, and then go back up. Sometimes what we'll do is we'll figure it out so that maybe someone can be on call for like 8 hours, and managing the patient off site, like in Albuquerque, like the second call person will manage the patient while I go sleep. I'll stay, I'll do the next day, I'll go down again, and then I'll do the next day. It's rare that happens, but sometimes it does have to happen. Sometimes even locally, if we have multiple donors, like recently, we had 2 or 3 donors going at once, and we only had 2 people on, and so you work, you go down for 8 hours, you get back up, you work, you go down. Those are the times that are really taxing, but we just try to take care of each other. If someone has time and they can work extra, they'll work to kind of help cover whatever times we need to sleep. So we have a really good team that works really well together to kind of like take care of each other and help each other out.
That's
So,
amazing. Those
yeah.
of you that joined in late, you might want to rewatch this whole thing because it's been great and I've learned so much. Jenny commented, "Thank you so much for sharing your experience, Marian. As a daughter of a successful heart transplant recipient, I appreciate your role both personally and professionally. It's truly amazing what you do."
Well, it's truly amazing. Like recipients go through so much on their end, and I don't even know like everything, but I know that it's pretty insane. So it's truly amazing that their family made it through to donations. So yeah, so thank you. I appreciate that comment though.
All right. If no one else has questions, you guys that are, like I said, those of you that attended late, please rewatch the beginning. It will be available on replay for you. And Marian, thanks so much for giving us your time on your
Of
day off.
course. Of
I
course. Well,
appreciate it.
it's not my day off. I'm still in the office. I just am on call.
Okay. All right. Good. 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 Well, thank you so much for teaching all of us, Marian, and thanks for so much for all that you do.
Yeah, no problem. Thank you, Chelsea. I love the whole platform and everything, and I love that you're helping us as a community. So I appreciate you.
Oh, thanks. Bye, friends.
Mwah. Bye.